Good afternoon, dear colleagues and dear patients. Today I want to talk about guideline-directed medical therapy of heart failure in patients with congenital heart disease. The first question is, why do we need a guideline-directed medical therapy for heart failure? Today we only know the data from patients with reduced ejection fraction, and there are around about 29 million of patients worldwide who suffer from heart failure due to reduced ejection fraction. And today we save 1.2 million lives by GDMT. These are the beta blockers, mineralocorticoid receptor antagonist, and the SGLT2 inhibitors, as well as the ACE inhibitors. Probably, of course, the cost, most people receive a beta blocker with a high therapeutic effect. However, as shown in this paper, we have an improvement of survival also in patients with mildly reduced ejection fraction between 41 and 49% ejection fraction, and in the group with preserved ejection fraction, there's also an improvement of survival with these four pillars. And today, the guideline-directed medical therapy was measured with a score as shown on the left side, and at higher the score, at the better the survival. But what about the mortality of heart failure in patients with congenital heart disease? These are the data of the German Heart Report from 2025, and in contrast to the decrease of mortality due to heart failure in adults, the mortality of congenital heart disease increased in Germany. The mortality of heart failure in adults decreased by 40%, this is the blue line, and the mortality of congenital heart disease increased by 20%, this is the pink line. On the right side, you see that the mortality is high in all patients, remains high in all patient group, most of all in infants. Around 210 and 250 infants die from heart failure due to congenital heart disease each year, and that is the second most cause of mortality in infants in Germany. And the overall mortality in patients with CHD increased from 483 to 685 today. Looking to the three therapeutic approaches to patients with congenital heart disease, there's the flagship of congenital heart surgery with high improvement of mortality due to heart surgery. There's no improvement of mortality with 6,000 percutaneous intervention each year in Germany. And there are disappointed results of pharmacotherapy in patients with congenital heart disease. And again, the perioperative mortality in patients with congenital heart disease decreased in children and adults in the last years, and there is a perfect development of this therapeutic approach. On the other side, Germany is the European champion in percutaneous intervention in patients with congenital heart disease, as shown in this slide. And in contrast to other countries, our mortality increased despite this high number of percutaneous interventions. What about the pharmacotherapy of heart failure and congenital heart disease? Is a methodological challenge. On the left side of this table, this is the prospective randomized trial of postoperative patients with congenital heart disease and without congenital heart disease who are treated with sacubitril/valsartan. And we can compare the difference between children and adults. There are a smaller number of patients in this trial with a lower age, and children have significantly lower systolic blood pressures. They have higher heart rates. They have a comparable reduced ejection fraction, and their NT-BNP value is half as high as in the adult group. Most of all, if the children are less sick than the adult patient who are recruited for this trial. Um, on the other side, we have the retrospective analysis from GDMT treatment from the Mayo Clinic as published in 2026 for the whole group of CHD patients with biventricular circulation and the group with Fontan patients with univentricular circulation, and they analyze the improvement of mortality with an uptitration of GDMT therapy, and in the retrospective analysis, mortality improved with a higher GDMT score. This is a slide from the original publication from the Mayo Group, who show the improvement of survival in patients who have a higher GDMT score, and the improvement of survival um, depends significantly on the GDMT score and on the improvement of the left ventricular ejection fraction. However, the retrospective analysis is in contrast to the prospective studies as shown on this slide. We have most of all in yellow neutral results of the therapy with beta blockers, AT1 antagonists, ACE inhibitors, sildenafil, bosentan, sacubitril/valsartan, and we have only the NT-BNP improvement in some patients with SGLT2 inhibitors. In contrast, percutaneous pulmonary valve replacement show acute mortality and benefit and long-term survival in those patients with a good indication with a very high anti-systolic volume of the right ventricle, a reduced right ventricular ejection fraction, and a wide QRS complex. However, there's no improvement of physical performance as in the other trials, and we have an improvement of hypertrophy in our bisoprolol trial. The right and left ventricular hypertrophy decrease after 6 months bisoprolol treatment. However, looking to the target heart rate in the treatment groups of the heart failure trials on infants, children, and adults, we clearly show the weakness of the pediatric studies with too high heart rates in the age groups below 10 years. It's only our CHF Pro Infant trial in infants and the BBGUT trial in older patients who reach the target heart rates as shown in the adult trials. Most of all, the cardiomyopathy patients in the US group show very high heart rates and receive only a beta blocker in 15% of cases. And there's a very high rate of death and transplant in this group. These data clearly show that we have to discuss about heart failure in patients with congenital heart disease that are not treated perfect in pediatric cardiology. We have to remember that heart failure is the main cause of mortality in congenital heart disease. Every second patient who dies from congenital heart disease is an infant. It is the second most cause of infant mortality. Patients with congenital heart disease often suffer from pulmonary hypertension that has an impact on prognosis, and more than 10% of patients with CHD have a genetic syndrome who have worsen prognosis. This slide shows the difference of the baseline values in infants with congenital heart disease in comparison with older children with a mean age of 8 years in the Panorama HF trial. The infants have very low systolic blood pressures. They have very high heart rates. They have very high left ventricular ejection fraction, and they have very, very high NT-BNP values. This is the reason because these infants are all in NEHF class 4, and they have a very high mortality. And we show an improvement with propranolol and the CHF pro-infant trial. These are the pathophysiological concepts of pharmacotherapy in patients with congenital heart disease. Most of all pediatric cardiologists use vasodilators to treat heart failure and pulmonary hypertension. In the last year, we use neurohormonal inhibition with ACE inhibitors and aldosterone antagonists. We try to improve contractility with digoxin and anodilators. And my concept to treat early life stress with propranolol is proven by a prospective randomized trial, but it's not accepted by the community. Looking to the guidelines from 2025 and the evidence in infants with heart failure, there's a clear recommendation in green to all drugs based on the cardiorenal and cardiocirculatory model. And we have no recommendation for beta blockers that based on the treatment concept of early life stress. Looking to the prospective studies, there may be evidence for digoxin and diuretics based on retrospective data. We have no improvement with inodilators, sacubitril/valsartan or carvedilol. There are very, very low patient numbers. Prospective studies, there are only one infant in the carvedilol trial and 6 infants in the Panorama HF trial. And despite the negative result from the US enalapril trial in infants with single ventricle, there's a recommendation to the therapy. And on the other side, we have around 50 infants who are treated with beta blockers in prospective trials, and we have no recommendation to this therapy. To understand the important difference of the treatment of myocardial failure and circulatory failure, we have to remember that most trials in adults and the Mayo data are patients with a broken pump, although they have we have to improve contractility and we have to reduce rotational speed of the pump. The blood pressure is sometimes high, and we need the lowest tolerated blood pressure, and vasodilators are probably improve prognosis in those patients. We have a complete other situation in infants with circulatory failure due to congenital heart disease. We have a healthy pump, and we may reduce the rotational speed. We have critical low blood pressures that induce neurohormonal activation and early life stress. And we have to avoid vasodilators who further decrease the blood pressure. And this is a therapeutic crossroad in infants with congenital heart disease. Should we further escalate neurohormonal activation by using ACE inhibitors or vasodilators? and there's no improvement of heart failure in this group, but there are increasing plasma renin activities by further escalation of neurohormonal activation with diuretic ACE inhibitors and vasodilators. On the other side, should we de-escalate neurohormonal activation with the beta blocker, for example, propranolol, and we have perfect data with a lower ROS score, lower plasma renin activities, lower heart rate variabilities. And we don't mention this successful therapeutic approach in the guidelines, and again, the mortality increase in our patients since 2010. If we don't have enough evidence from prospective studies, we have to measure the result of our therapy, for example, with 24 heart rate variability. And on the left side, these are the our data of medical therapy of heart failure in infants with congenital heart disease and the high frequency power. This is a vagus parameter from the 24-Holter ECG. And there are very low values in patients who receive digoxin and diuretics and metoprolol. And we have better, nearly normal high frequency powers in patients who are treated with propranolol. In the long-term follow-up of our patient, we can show that vagus activity remains good in our patients with congenital heart disease who are treated in infancy with a beta blocker propranolol. In this case, we use a vagus parameter RMSSD. In our data clearly show that the vagus activity remain normal in the mean age of 9 years, and compared to the Munich data who show a very low RMSSD value in the long-term follow-up of patients with congenital heart disease at an age of 33 years. To understand the different use of beta blockers in infants and older patients, we have to remember the effect of the different beta blockers on heart rate and vascular resistance. We have the best effect of propranolol on lowering heart rate and to increase the systemic vascular resistance. We have a lesser effect of metoprolol on heart rate, and we have decrease of the systemic vascular resistance in carvedilol-treated patients. We only use carvedilol in cardiomyopathy patients and do not use carvedilol on infants with congenital heart disease. We further have to realize that we have a special situation in children with congenital heart disease and genetic syndromes that have the highest mortality, most of all in the middle income countries like Malaysia, who have cardiac surgery, but many of these patients with Down syndrome don't reach surgery. 31% of patients died prior to surgery. And many patients who are treated with propranolol in our studies suffer from additional Down syndrome. And our data clearly show that these patients have higher heart rates, they have lower heart rate variabilities, and they have higher NT-BNP values, and the mortality is higher in the Down patients despite the cardiac surgery in a high volume center. This paper shows the non-invasive monitoring of the heart failure treatment with elafibranor in an infant with atrioventricular septal defect and Down syndrome. This is complete non-invasive monitoring of heart rate variability, and blood pressure with pulse velocity. And this is a cardiac decompensation treated with enalapril and hydrochlorothiazide. And on the intensive care unit, the blood pressure further decrease after milrinone therapy. There are very low blood pressures and the baby do not improve. The colleagues have to treat with norepinephrine and furosemide to stabilize the baby. The heart rate variability, the vagus activity in green is very, very low. And in the morning, they stop the wrong therapy with enalapril, milrinone, and norepinephrine, and use a beta blocker, metoprolol, and the baby improves. And this is a 6 month course of the baby with atrioventricular septal defect and severe heart failure due to Down syndrome. There are different institutions with different pharmacological approach. We compare the fast Fourier analysis of the baby with the normal values. Is a 5% percentile. This is the lowest value in this patient group, and we have in green very, very low high frequency powers, and the situation completely escalate with 6 months. There's a shunt reversal and a complete loss of vagus activity, and that improved after pulmonary banding. And this slide describes my role in pediatric cardiology within the last 25 years. The New England Journal of Medicine reports that 9 of 10 doctors agree that 1 of 10 doctors is an idiot. I'm sorry.